Well, welcome everybody to this atrial fibrillation education module. Today I want to walk you through a comprehensive management of atrial fibrillation overview, what I call the three-pronged approach. I am Dr. Karen Phillips. I'm a cardiologist and heart rhythm specialist, and I head up the Brisbane AF clinic, which is a comprehensive atrial fibrillation management clinic that's based at Greenslopes Private Hospital in Brisbane. Now, just a reminder about the significance of atrial fibrillation for health. This is not a benign condition, and it sits up there with cancer and heart failure and coronary disease, that atrial fibrillation is associated with the increased risk of death in the general population. We see increased mortality rates, and in particular for women, it cancels out their survival advantage that they usually enjoy over their male counterparts. So this is not a benign condition. And it's a complex condition to manage properly. Why is that? Well, as we'll see, it's caused by or associated with a range of cardiac conditions and other comorbidities and risk factors, such as hypertension, obstructive sleep apnea. It confers an increased risk of cardiac failure over time, an increased risk of stroke that we're mostly all familiar with, increased risk of death, as we've just seen, versus patients who are in sinus rhythm. And there's an increasing complexity for patients to navigate different rhythm control treatments on offer. So understanding the role of antiarrhythmic drugs, where cardioversions fit in, ablation therapy, which has become far more mainstream these days. And of course, there continue to be rapid advances in new therapies in atrial fibrillation, such as left atrial appendage occlusion devices. So we need a comprehensive management approach to atrial fibrillation, and this is what I call the three-pronged approach. And we're going to break this down today, and this is quite simply how I approach every patient with atrial fibrillation. We need to take a look at the big picture, have a look at a stroke prevention plan for patients, and have a look at a rhythm plan for them as well. So we're going to step through this. So the big picture, it's important to appreciate that for the majority of patients, atrial fibrillation is just a symptom of heart disease. So the cause of AF is now accepted to be disease of the atria. So there is some sort of condition which leads to overstretching or scarring of the atria, and that subsequently manifests as the rhythm irregularity that we see as atrial fibrillation. So atrial fibrillation is simply the final common pathway of many cardiac conditions, and they include most commonly heart valve problems, for example, mitral regurgitation, coronary disease, previous myocardial infarction, and any cardiomyopathy or cardiac failure of any cause can lead to atrial fibrillation. We also know that there are other causes, other conditions, medical conditions that can lead to atrial fibrillation, and this includes chronic respiratory disorders. Of course, the heart and lungs work in close concert, so chronic respiratory disorders can bring on atrial fibrillation. Hypertension, extremely common. Long-term elevated pressure back on the heart leads to atrial stretching and scarring and atrial fibrillation. Obstructive sleep apnea. Obesity is a lot of Australian research pointing to obesity being a direct contributor to atrial fibrillation development. And of course, an oldie but a goodie, thyroid trouble, that if you're hyperthyroid, that can easily trigger atrial fibrillation. So the first question for any patient that comes through my door with atrial fibrillation is, what's causing your AF? What other cardiac conditions or issues need to be managed? And what other risk factors and interacting conditions also need to be managed for best long-term outcomes? In particular, for patients who are looking at rhythm control strategies, they have a much better chance of staying in sinus rhythm long-term if we're dealing with all of the reasons why their heart developed atrial fibrillation in the first place. We're very familiar with atherosclerotic risk factors, so patients with coronary disease, targeting primary or secondary prevention. We're trying to manage blood pressure, high cholesterol, diabetes, smoking, etc. But we need a new appreciation for the fact that there are risk factors that lead to atrial fibrillation as well. So we have to get a lot better at upstream management of some of these risks to either help prevent AF or help reduce its progression or mitigate some of the risk, health risks associated with it. And some of these are in common with other cardiac risk factors, but as you'll see, hypertension that we already talked about, and obstructive sleep apnea, cardiac failure of any cause. Alcohol, however, is very specific to atrial fibrillation, toxic for the heart, and a very big lever to pull that promotes atrial fibrillation. Family history, obesity, physical inactivity, these are all risks that need to be addressed for good long-term management in atrial fibrillation. So the big picture management goals therefore need to be assessing and treating any of these other underlying heart disease and risk factors. So all patients with atrial fibrillation should have a 12-lead ECG. That's diagnostic for the rhythm issue, but it also tells us or alludes us to any other cardiac issues which may impact management. And all patients need an echocardiogram to assess their cardiac function and to look for other structural heart disease, which will help guide management. Patients need general blood workup. In particular, we mentioned thyroid function, but also renal function, which helps us to manage NOAC therapy. All patients need to have their blood pressure profile assessed. To be honest, the majority of patients with atrial fibrillation that I see in my clinic do have hypertension. So it's often the case, I say to them, you have to prove to me that you don't have high blood pressure rather than the other way around. So having a look at assessing blood pressure profile, whether it's with home blood pressure monitoring or a 24-hour monitor. Screening questions for obstructive sleep apnea are important for AF, and looking at other risks, including their weight, physical activity levels, and alcohol use. And of course, the big picture in general practice, this should lead you to create a chronic disease management plan. So patients with atrial fibrillation, we need to document what are the cardiac conditions, what are the interacting medical conditions and risk factors, put these into a plan and establish some annual goals for management as part of their bigger picture and overall condition. Okay, let's step on to the second prong, which is stroke prevention. And just a reminder about ischemic stroke. The most common cause of ischemic stroke in Australia remains hardening of the arteries, so atherosclerotic cerebrovascular disease. So the same way that patients can have a coronary from cholesterol plaque blocking a heart artery, the same process happens in the brain. Of course, there's also hypertension, but with atrial fibrillation, we're predominantly interested in cardiogenic embolism. A reminder that the percentage of strokes attributable to AF increases with age. Obviously, that parallels the increasing incidence and prevalence of AF with age, and of course, the attributable strokes due to atrial fibrillation increases with age. So by the 8th, 9th decade, 30 to 40% of strokes may be due to atrial fibrillation. So stroke prevention is hugely important. It's one of the biggest health risks for patients with atrial fibrillation over their lifetime. And of course, stroke due to AF is mostly due to cardiac thromboembolism, and oral anticoagulants we know reduce risk. How do we assess stroke risk? And it's the CHADS-VASc score, the clinical tool that we've been using for the last decade or so, which continues to be current in all clinical guidelines around the world. And of course, we tab up and give points for the following risk factors: so congestive heart failure or left ventricular systolic dysfunction, reduced ejection fraction, hypertension, age. So if you're over 75 years, you score 2 points, or 65 years, 1 point. Diabetes, previous history of stroke, history of vascular disease, and female sex increases risk. So who should be anticoagulated? Well, quite simply, if you have any runs on the board, if you score any points, you should be having the conversation with patients. But in general, the guidelines say that a score of 2 or more merits long-term anticoagulation. A quick comment about female sex. Women do have a higher risk of stroke than men with atrial fibrillation at a younger age. So female sex confers increased risk for age, but not generally for the other risk factors. So So women over the age of 65 should consider anticoagulation, whereas men, it would be over the age of 75 without other risk factors. What are the rules for anticoagulation for AF? I stick to some simple ones. Rule number one, either prescribe a NOAC or don't prescribe anything at all if the patient is low risk. So just a reminder that aspirin is no longer recommended for AF protection. It's out of the guidelines. So a NOAC or nothing at all if they're low risk. Rule number two, NOAC is now first-line recommended anticoagulant. Warfarin is really only used for patients with mechanical heart valve replacements or rheumatic mitral valve disease, or in patients with significant renal failure who can't take NOACs, or for patients who are intolerant to NOACs. So you should be reaching for a NOAC first line. They're efficacious and they're considered to be safer than warfarin therapy. And of course, anticoagulants only work if patients take them, and their safety is predicated upon being the right dose. So we need to be reviewing NOAC compliance, tolerance, and dose for age and renal function weight annually. Which NOAC do you choose? We have three excellent choices available to us in Australia. And from my point of view, there's not much between them in terms of efficacy. All NOACs seem to be similarly efficacious for stroke prevention at the correct dosing. In the head-to-head trials compared with warfarin, it was only Pradaxa at the highest dose that was shown to be superior to warfarin. A reminder that Pradaxa and Eliquis, so dabigatran and apixaban, the drug names, are twice daily dosing versus Xarelto or rivaroxaban, which is the only one which is a once daily dosing, and you may consider that depending on concerns about patient compliance. Pradaxa has the instant reversal antidote called Praxbind, so that might be a concern for some patients or interacting medical conditions, that there has to be an instant antidote available. For the other agents, we can administer Prothrombinex complex in hospital to effectively reverse them. And another important note is please avoid using a lower dose than recommended. There is really minimal gain for a reduction in bleeding risk versus significant loss in stroke protection effect if patients try to err on the side of, well, I'll take a blood thinner, but can I just take a low dose? We should be using the recommended doses. Okay, we'll step on to number 3 out of the three-pronged approach here, which is the rhythm plan. Now, there's no longer any debate. Sinus rhythm is clearly the best for heart and for long-term health. So patients need to understand the implications of this condition and the pros and cons of the different treatment strategies which may help to restore and maintain sinus rhythm over the longer term. So this can be pretty tricky to negotiate. Patients need to get a handle on, what are antiarrhythmic drugs, what's their role, what are the risks, how are they monitored over time, who might need cardioversions, when are they used, and catheter ablation therapy. As I said, it's become much more mainstream these days. And we're going to have a look at the benefits for catheter ablation therapy, because it's really been a game changer for improving prognosis for atrial fibrillation. So who should be offered catheter ablation therapy and when? So in particular, in general practice, I think it's important to understand who should be the priority for rhythm control. Before catheter ablation therapy came along, there basically comparative trials looking at rate control versus rhythm control using antiarrhythmic drugs were fairly negative, and that's because antiarrhythmic drugs really can't improve prognosis over the longer term, and they were often associated with patients being withdrawn from anticoagulation, thinking, well, if they're in sinus rhythm, they don't need anticoagulants. But in the new era where we have catheter ablation therapy, definitely the evidence points to patients maintaining sinus rhythm having better heart and health outcomes. So who should be the priority for rhythm control? Well, definitely symptomatic patients. So atrial fibrillation reduces quality of life. It affects mental, social functioning, and so patients deserve to have a better quality of life. So symptomatic patients should be put up for treatment for their atrial fibrillation to maintain sinus rhythm. As we'll have a look at some of the evidence, patients with cardiac failure and LV dysfunction, treating their atrial fibrillation improves outcomes. It saves lives, it improves ejection fraction. So these days, much in the same way that if a patient has their valve problem corrected or their coronary disease addressed, atrial fibrillation is an important treatment target for patients with poor cardiac function and cardiac failure. And of course, younger patients, as we'll see, there's a compounding effect over time on cardiac health from atrial fibrillation. So the younger patients are, the more consideration they need about, well, what health effects will this have long term, and what are the priorities. Let's flip the coin to the other side and say, well, okay, in this day and age, when do we accept permanent atrial fibrillation and simply aim for rate control, as well as stroke prevention, part of the three-pronged approach? Well, quite simply, after all is said and done, if a patient has failed rhythm control attempts, then there's usually a discussion around it's either failed to respond to therapy, or a patient along their journey may elect, like, I've had enough of these treatments and I'm prepared to accept the atrial fibrillation. I think the opposite to a young patient who has many years ahead to protect their health. If patients are advanced age and truly have no symptoms with good cardiac function, they're a group that we may choose to leave alone. Obviously, again, the three-pronged approach, but we may elect to leave them in atrial fibrillation. And of course, another tricky one is if patients present with long-standing AF and they're asymptomatic with good cardiac function, that can be another tricky one. As we'll have a look at, patients with long-standing atrial fibrillation can prove very difficult to get back to sinus rhythm. And so when all is said and done, if they already have good quality of life and good cardiac function, it may not be worth the extensive efforts to get them back to sinus rhythm. All right, let's do some deep diving into AF ablation and how it's changed therapy for atrial fibrillation. It really has it changed the prognosis for atrial fibrillation. And this is basically a report from back in 2014, which was one of the first publications really to highlight that maintenance of sinus rhythm after radiofrequency ablation was associated with a reduction in cardiac mortality in patients with AF. So very promising, and unlike antiarrhythmic drugs, basically ablation for atrial fibrillation is maintaining long-term sinus rhythm for many patients and allows improved prognosis. Another pivotal publication, 2018, in the New England Journal of Medicine, and this was in the subgroup of patients with atrial fibrillation and heart failure. And the conclusions from this randomized controlled trial was that catheter ablation for AF in patients with heart failure was associated with a significantly lower rate of death from any cause or hospitalization for worsening heart failure than was medical therapy. So another groundbreaking piece of evidence. And so the guidelines are changing in response to some of these publications. And last year, the American Heart Association basically changed their guidelines for patients with atrial fibrillation, heart failure, and reduced ejection fraction. And catheter ablation therapy is now recommended as first-line therapy for patients deemed suitable for rhythm control. And another illustration of that trial and the startling results. So Castle AF was the name of that trial, published in the New England Journal of Medicine. And as I said, it was a randomized controlled trial of patients with heart failure with a reduced ejection fraction, 35% or less. And they had implantable cardiac defibrillators. And the significance of that is because we get rhythm monitoring information that patients with pacemakers or cardiac defibrillators, we get a record of every episode of atrial fibrillation. We can track when they're in atrial fibrillation and the percentage of time that they spend in atrial fibrillation, and that can be converted into a burden, total percentage of time that they're in atrial fibrillation versus sinus rhythm. The black and white results from this trial: death from any cause. If you had ablation therapy, you had improved probability of survival over the 5-year follow-up from this study, and a reduced chance that you would be hospitalized for worsening heart failure. Key significant health outcomes for patients treated with ablation therapy if you have heart failure and a reduced ejection fraction. I want to bring your attention to this AF burden concept and have a look at how much atrial fibrillation reduction was achieved in this trial for patients with ablation versus medical therapy. Atrial fibrillation burden, as I said, just tells us the percentage of time that patients were in atrial fibrillation as recorded by their devices. And the important thing that you can see here is, in red here is patients who had AF ablation. At 12 months after the trial, their percentage burden of atrial fibrillation was around 20%. So not 0%. And obviously this is a mean result. So some patients may have had 0 atrial fibrillation and some may have had 30 or 40%. But on average, 20% burden of AF versus around 50% and increasing again for medical therapy. So I think it's an important point to understand that we are not curing AF. And ablation therapy doesn't necessarily have to. So some patients may get amazing results and be rendered completely free of AF for extended periods of time. But maintaining sinus rhythm the majority of the time, long-term, essentially translates into cardiovascular health benefits for heart failure and mortality. I want to step through a couple of points around atrial fibrillation that helps us decide on rhythm control and some of this decision making with patients. And one of those is an appreciation of the patterns of AF and the implications for prognosis and treatment. So a quick reminder of the patterns of AF that are described. Paroxysmal AF refers to patients, basically you have episodes of AF that terminate spontaneously within 7 days of onset. So the AF starts, but importantly, it always stops by itself. Persistent AF is a pattern which refers to episodes of AF that last longer than 7 days or were medically reverted with cardioversion, otherwise the episode would have persisted. And long-standing persistent AF refers to atrial fibrillation of continuous duration for 12 months or longer. So what are the implications of these different patterns? And to some extent, it's indicating earlier and more advanced stages of AF and cardiac disease. So paroxysmal AF is essentially, the easiest pattern of atrial fibrillation to treat and get control of. As I said, they're intermittent episodes that self-terminate. If untreated, this may progress to persistent AF over time as the episodes start to increase in frequency and duration. Antiarrhythmic drugs can generally offer good control to this pattern of atrial fibrillation, but they patients also stand to get an excellent outcome from AF ablation. So this is the easiest pattern of AF to stomp on with ablation therapy. It can offer success rates of 70 to 80% long-term without patients needing to take antiarrhythmic drugs. So patients can potentially be free of their atrial fibrillation for many, many years after ablation therapy. Now, persistent AF, as I said, this has different implications. these are episodes that last longer and won't revert by themselves without intervention. Unfortunately, this signals more extensive atrial disease. And we know that these patients have higher recurrence rates of AF with all types of therapies. And that needs to be taken into account with the decision-making and conversations. These patients still get good outcomes from AF ablation, but I tell them always this is going to recur. You've got a higher chance of needing repeat ablation therapy over time, potentially use of antiarrhythmic drugs on top of ablation therapy, sometimes intermittent cardioversions. So the battle for sinus rhythm goes on, and it's not that it's not worth it, but we're having a different conversation about the implications of treatment over time. What about long-standing persistent AF? Well, as I said, this can be tricky to treat, and generally only experienced AF treatment centres may consider rhythm control in this case. Patients can still get good success, but they will often require multiple ablation procedures over time and adjunctive antiarrhythmic drugs in order to achieve sinus rhythm long term, but it is still possible. And the red flags that we're looking out for are indicators that the therapy is unlikely to be successful, and that's severe left atrial enlargement, indicating severe atriopathy, other severe cardiac comorbidities that will work against us to maintain sinus rhythm, and to some extent advanced age and morbid obesity are also some red flags. So as I said, I would never say never. I take every patient individually and discuss, and to some extent, as long as the therapies are safe, we can afford to fail rhythm control. It's in some ways better to try and fail safely than to have never had a shot at sinus rhythm again. But sometimes if things are equivocal, some of these red flags may steer us away from trying to attempt to get patients back to sinus rhythm. All right, and of course, the incentive is that there is an opportunity early on to revert AF, and the longer that you leave AF, the harder it is to treat. So this decision-making right at the start of the journey is important. Another important point, as I said, when we're deciding about rhythm control, it's based on patients predominantly having symptoms from their AF. Well, how do we assess symptoms? And of course, common symptoms of AF, most of us are familiar with, and the majority of patients may volunteer these: palpitations, breathlessness, dizziness. Patients often note that their exercise capacity is diminished, reduced endurance with activity. Some patients get chest pain and tightness. You can get adrenergic symptoms like sweating associated with atrial fibrillation. Some patients will just tell you they don't feel well, so malaise. Poor concentration, it can affect people's mentation. Urinary frequency is another interesting one. Irritable mood, it affects people's mental health and emotions. And poor sleep is another one. So listen carefully for all of these types of symptoms. Some patients, however, the most common symptom I would say that underpins most patients with atrial fibrillation is they notice increased fatigue and lower energy levels associated with atrial fibrillation, and sometimes poor motivation for activity. And sometimes if I'm not sure, I'll simply ask patients, can you reflect on your health and sense of well-being now that you're in atrial fibrillation compared with previously? Do you think there's been a change in your overall health, especially for patients with persistent atrial fibrillation, because sometimes it can sneak up on them and they can't remember what it used to feel like being in sinus rhythm. And obviously, if there's any indecision, sometimes it's better to trial sinus rhythm, a cardioversion, for example, that may help a patient assess if they feel better in sinus versus atrial fibrillation in terms of their long-term journey. A quick note, and this is important, that women, it's important to know that women more commonly have atypical symptoms with AF. So when we're trying to judge symptoms, women generally have more severe symptoms from AF, but they're less likely to suffer from simple palpitations. As I said, they may be more atypical symptoms that you've got to work out. More commonly could be chest pain or dizziness. And it can lead to difficulties with a diagnosis initially if AF is not actually suspected. All right, so that brings us to the end of the three-pronged approach. Basically, this sits in every AF clinical guideline. So this is a sort of flow diagram from the European Society of Cardiology AF management guidelines that highlights the aspects of integrated AF management. So the patient sits at the center of this in terms of their education and decision-making around their AF care. And of course, highlighted here is the three-pronged approach: stroke prevention, control with rate or rhythm control, as we've talked about, and of course, management of cardiovascular risk factors or other comorbidities. And this sits in amongst a management plan which includes patient education and self-management, lifestyle modification, psychosocial management, strategies to promote medication adherence, in particular NOACs, and a multidisciplinary team approach, which is essential, and structured follow-up and clear communication between primary and secondary care, between GPs and specialists. And of course, that's the three-pronged approach. A simple overview to comprehensive management of atrial fibrillation must include a plan for the big picture, for stroke prevention, and for the rhythm plan. And of course, in general practice, this is most easily incorporated into a chronic disease management plan. Okay, so we're going to leave it there and move on to a couple of case studies. So patients that you might see in general practice, and how do we use the three-pronged approach. Case study number one is a 58-year-old male, Andrew, and he's made an urgent appointment with you today in general practice because he developed palpitations today that have been ongoing for 4 hours. He's usually fit and well. He's part of the middle-aged men in Lycra brigade, and he cycles around 150 to 200 K per week. He has been getting short palpitations after exercise over the last 12 months, but today is the longest episode that he's had, and he's managed to come in while he's still got symptoms ongoing. He has no past medical history. He's not on any medications. And his obs that you take, his blood pressure 116 on 68 millimeters of mercury, is okay. But his pulse is rapid, 115 beats per minute, and irregular. His BMI sits at 26. You arrange an ECG, and this is what it looks like. Atrial fibrillation, irregular, and the heart rate around 118 beats per minute. But nothing else major to see on the ECG abnormal. So what's our immediate management of Andrew, 58-year-old gentleman? Well, the first decision is he hemodynamically stable? Are we going to send him to the emergency department versus outpatient management? And of course, you'll never be criticized for sending someone with rapid AF to emergency. But he seems well enough, and so we're going to try our three-pronged approach today, and we think we can manage him as an outpatient. So three-pronged approach for Andrew is the big picture. So he has no history of comorbidities, but at some stage we want to take an alcohol history off him. We arrange some bloods and tell him he's going to need some cardiac testing. He's got a cardiac condition that's been diagnosed today. And that's at least an echocardiogram, but given he's a middle-aged man, perhaps it's the right time to screen for coronary disease as well. So an exercise stress echocardiogram, equally may be helpful. Stroke prevention, we tab up his CHADS VASC score. He's 58 with no other comorbidities, so his CHADS VASC score is 0. So we reassure him, yep, there can be a risk of stroke with this condition, but we don't need to start you on long-term blood thinners, so no action required today. And rhythm plan. he sounds to have a history of paroxysmal atrial fibrillation that's developed over the last 12 months or so. All the episodes seem to have stopped by themselves previously, but he is in rapid AF today. So he's symptomatic, he's young. So it suggests that he probably will want to discuss rhythm control plan with a cardiologist. But for today's purposes, we feel uncomfortable sending him home with a rapid heart rate. So it would be reasonable to prescribe a beta blocker just to bring his heart rate down. Whether that needs to continue long term, might be a discussion or come up as part of the rhythm control plan that might be developed with cardiologist. All right, case study number 2. 68-year-old female Andrea, she had a routine appointment scheduled for you today for a prescription renewal. So she has a history of hypertension, usually takes Olmetec Plus, and she also has a history of essential tremor that she's been managed with propranolol therapy. You check her blood pressure today before repeating her prescriptions, 136 on 86, that's okay. But you note that the pulse is 95 and it's irregular today. Her BMI is 34, so she's in the obese range. On further questioning, she says she's been a bit more tired of late. She had a recent upper respiratory tract illness and has been feeling like she's dragging herself around a bit since then. ECG today, basically heart rate 95 beats per minute, and the conclusion was atrial fibrillation, otherwise normal ECG. So we've made a new diagnosis of atrial fibrillation in Andrea today. So immediate management, and again, that decision about are we managing as an outpatient or should it be inpatient referral sent to emergency. She's hemodynamically stable. She's not particularly tachycardic on her medications, and she might be a bit bemused if she came for a prescription renewal and got sent off in an ambulance. But suffice to say, we can manage her as an outpatient today. So let's have a look at our 3-pronged approach. So the big picture, Andrea has comorbidities of hypertension and obesity that are relevant to her atrial fibrillation. We also want to take an alcohol history, and because of the other comorbidities, obstructive sleep apnea could be on the cards here as well too. Similarly, we arrange bloods and an echo, or again, you could always opt for an exercise stress echocardiogram for increased value screening for ischemic heart disease. And stroke prevention, we tab up Andrea's CHA2DS2-VASc score. She's 68, female, and has hypertension, so her CHA2DS2-VASc score is 3. So we need to basically commence a NOAC today for Andrea, and that would be a NOAC of your choice. And hopefully you've got previous renal function to be able to do the correct dosing today. And of course, a rhythm plan. She's probably symptomatic. The fatigue is probably a symptom from the recent onset atrial fibrillation. She's still young. She's in her 60s. She's got 15 or 20 years of life expectancy still. And in her case, we're not sure how long she's been in atrial fibrillation because it's an incidental finding. So we probably want to bring her back in a few days to a week's time to have a look at the results and repeat her ECG and see if she's still in AF at that time, review her symptoms again. But she will probably also want to discuss rhythm control plan with a cardiologist or EP cardiologist. All right, so that's the end of AF education today, a 3-pronged approach. Hopefully that gets you all started with a reasonable strategy for comprehensive management of atrial fibrillation patients. Thank you.